Well, hello, hello, hello. Happy Friday. Hope everybody is doing well. All right, hard to believe it is December, less than a month until 2025. And I am here to answer questions related to hyperthyroidism, Graves' disease, hypothyroidism, Hashimoto's. So if you have questions, now is the time to ask them. Before I get to questions, I'm going to just go over a few resources for those who are new to this group and new to me. So I do have a podcast. It's called Save My Thyroid, and you could check it out by visiting savemythyroid.com or visiting your favorite podcast platform and typing in Save My Thyroid. And so the podcast has a little bit more focus on hyperthyroidism, just because most of the other podcasts out there, or pretty much all of them, focus more on hypothyroidism and Hashimoto's. So a little bit more of an emphasis on hyperthyroidism, but I will say that most of the episodes will benefit those with either hyperthyroidism or Hashimoto, especially the guest episodes, but most of the solo episodes as well. And then my original website, so savemythyroid.com, that I released that in 2021 when my podcast came out about 3.5 years ago. Naturalendocrinesolutions.com has been around for almost 15 years. 2010 is when I launched that website. Has hundreds of articles and blog posts related to thyroid health, thyroid autoimmunity. Have a supplement line as well, so you can check that out at thyroidsave.com. And a few other resources. I have 3 thyroid health related books, 2 on hyperthyroidism, 1 on Hashimoto's. So my first book, Natural Treatment Solutions for Hyperthyroidism and Graves' Disease, released in 2011, and just in 2023, just about a year ago, released the 3rd edition. And Hashimoto's Triggers is a comprehensive book, possibly the most comprehensive book on Hashimoto's, at least when it comes to finding the triggers. And then Hyperthyroid Healing Diet, my most recent book, released that in spring of 2024. And then I have a YouTube channel, so where pretty much all of the podcast episodes get posted, and then so if you want them in video formats, and you might want to check out YouTube. And then also I have a quiz if you want to take the Save My Thyroid quiz at savemythyroid.com/quiz. And that is it. So I will now be answering questions, but I will actually leave these resources up just in case, not in case, people in Facebook, people come and go. So definitely there'll be people trickling in late, people leaving early, just people poking in their head. All right, so we got Louisa. Hi, Louisa. Thanks for joining us. And we got Winterkind from Germany. Awesome. Thanks for joining us from Germany. Okay, and Hal 9000. What is the role of rhodiola in Graves' disease? Well, rhodiola is an herb, and I mean, I can't say that it really plays any role specifically for Graves. It's not something I give everybody. I do like rhodiola for adrenal support, and it can support the HPA axis, as can some other herbs, so the hypothalamic pituitary adrenal axis. And so rhodiola, again, for someone with adrenal issues, I would say more so if they're having low cortisol issues. But like I said, it's not something I recommend to everybody. It's not because I don't like rhodiola. It's just that there are other things out there, other herbs, other natural agents. And as a healthcare practitioner, you need to pick and choose. So I do like it. But like I said, for Graves, a lot of people do have adrenal problems, but different practitioners will recommend different natural agents. And rhodiola is one of those agents. Elise, thank you so much for all your sharing. It's so hard to get access and support for dealing with Graves naturally here in the UK. You are welcome, Elise. Yeah, I mean, really, even in the United States, I mean, in most cases, there's not a lot of support naturally. There's not a lot of information out there on supporting hyperthyroidism, Graves' disease naturally. So it's not just in the United Kingdom, but pretty much everywhere. That's why, I mean, the reason why I focus on it, of course, is because I personally dealt with Graves' disease. If I didn't deal with Graves' disease, I almost sure would, almost certain I wouldn't be here doing what I'm doing. I wouldn't have written 3 books, even though one of them's on Hashimoto's. Still, the reason I got into what I'm doing now is just because of my own personal journey with Graves' disease. And that's why I focus more on hyperthyroidism, even though again I wrote a book on Hashimoto's as well, and again there's information that I present that also benefits people with Hashimoto's, but the majority is for those with hyperthyroidism Graves, just because there's not a lot of information out there. So Louisa says, what can someone take if T3 and T4 are normal but TSH is low? So you're talking about subclinical hyperthyroidism, assuming you're not taking anything and your TSH is low, but T3 and T4 are within the lab range and perhaps within the optimal range. So I mean, you could take like someone with subclinical hyperthyroidism, they could take something like bugleweed to help with the TSH. The problem is that it's not addressing the cause of the problem. So you don't want to just focus on the TSH. You want to try to address underlying causes. And so with subclinical hyperthyroidism, I do still focus a lot on the gut, on the adrenals, on reducing one's toxic load. So those are like 3 big areas, really, regardless of what someone has. But that's what I focus on. If someone has nodules, number of nodules, like conditions such as multinodular goiter, not toxic multinodular goiter. Well, I guess toxic too. Toxic multinodular goiter, typically we'll talk about overt hyperthyroidism where T3 and T4 would be elevated, but just multinodular goiter sometimes will cause that TSH to be depressed and thyroid hormones might be normal. So again, we're just trying to address the cause of the problem, and it usually will take a decent amount of time for that TSH to increase. All right. So Hal says, does the HPT axis know about the enlarged thyroid gland when releasing TSH or TRH? Meaning, does the release immediately get absorbed by the thyroid? Does the release? I'm not sure I understand. So, I mean, HPT axis, hypothalamic pituitary thyroid axis. Does it know about the large thyroid? So does the release immediately get absorbed by the thyroid and there is suddenly a big release of thyroid hormone? Maybe you could reword this differently. And it also would help like to know, like, I assume this is your, like you have a goiter, you have an enlarged thyroid gland, are your thyroid hormone levels within range? Do you have, is it more hyperthyroidism, a hypothyroid case? So does the release immediately get absorbed, the release of thyroid hormone get absorbed by the thyroid? No, not thyroid hormone, but never mind. That wouldn't be it. Yeah. Does the release of TRH, so like the TRH being released and then get absorbed by the thyroid, and then there's a sudden big release of thyroid hormone. So yeah, so TRH gets released by the hypothalamus, and then it communicates. So the hypothalamus essentially communicates with the pituitary gland with TRH. Pituitary gland then releases TSH, and TSH tells the thyroid gland to either make more thyroid hormone. Well, that's what it does, and then if someone has hyperthyroidism, of course, then it'll slow down the production of TSH. So you're saying, does the release get immediately absorbed by the thyroid? So like in the case of pituitary gland releasing TSH, and that bind to the thyroid. So, I mean, again, I'm not sure if I understand, but there's not really, it really depends on the situation, but it's not like TSH binds to the thyroid and then there's a sudden, like, huge release of thyroid hormone. Um, and again, I'm not sure if you're talking what situation, like if you also, like if you have Graves and you also have TSH receptor antibodies associated with that. So maybe you might want to kind of elaborate a little bit more on the question. So winter kind, did you have patients that couldn't take thyroid blockers? When does the thyroid need to be taken out? What's like the worst case scenario? Yeah, I mean, it's not uncommon for people to be unable to take antithyroid medication such as methimazole, PTU, and I mean, so there are other options. Again, a lot of my patients take natural agents like bugleweed or higher doses of L-carnitine, tartrate, uh, 1,000 to 2,000 milligrams twice per day, according to the literature. Blocks the entry of thyroid hormone into the cell, and that's an option. There's a cholestyramine, which I've written about, which is a binder, not specific for hyperthyroidism, but if someone is unable to take the antithyroid medication, and let's say the natural agents aren't effective, I've had some on cholestyramine, low dose naltrexone or LDN is another option. So I would I mean, in the case of, let's say, Graves' disease, I mean, when you say when does the thyroid need to be taken out, I mean, there are other situations like if someone has thyroid cancer, then that's a completely different situation. But if someone has Graves' disease and they're unable to take anti-thyroid medication, I wouldn't say that in that scenario they should automatically resort to thyroid surgery. There's again the natural agents. There's cholestyramine. There's again low dose naltrexone. And then obviously, while these are just things to manage the symptoms, while doing this, you want to address diet and lifestyle factors. I recommend certain functional medicine tests to try to find, remove triggers, and that depends on the person. And that's why we do a health history. But yeah, so I think again, there's definitely a time and place for thyroid surgery, but some people they're too hasty when it comes to thyroid surgery. So yeah, my goal if someone's working with me and if they can't take the antithyroid medication, then we'll try to take a natural approach. If that doesn't work, then we'll see about like if they could get a prescription for cholestyramine, LDN. At least in the United States, is pretty easy to get a prescription for. And while doing this, we want to try to find, remove triggers, heal the gut, correct other underlying imbalances. So yeah, I mean, that should be like last resort. Everybody's different. I mean, and I will say, I mean, if someone has like any type of like in the case of a goiter, a large goiter, and if they have any type of obstruction, then that might, I mean, especially if they have difficulty breathing, swallowing in that situation, then that's when surgery might, I mean, not might, but again, depending on the severity, very well could be something that the person might need to do. But yeah, in case of, let's say, Graves, when someone is unable to take antithyroid medication, that alone shouldn't mean that the person needs to get surgery. Although, unfortunately, in many cases, endocrinologists will say that's the next step. Please repost the website where I can purchase gut healing. Um, like you mean the supplements, like gut healing supplements? Do I have a banner? Because I do have. Hold on a sec. Yeah, I do have this. I don't know. I don't know when you say gut healing. I do have a guthealingbundle.com. So you could check that out. I'm not sure. Then my other websites, if you talk about the websites, like savemythyroid.com is where you could definitely check out podcast episodes where I spoke about gut healing. and then naturalendocrinesolutions.com, my main website, where I have a lot of articles and blog posts. Okay, so thanks for clarifying, Hal. So I do have long-term Graves, a large gland. TSH follows circadian rhythm, highest at 2 to 4 a.m. Does the big gland produce a sudden spike in thyroid hormone at 2 to 4 a.m. because supposedly more TSH then? Yeah, good question. I am not sure if you get more thyroid hormone at I mean, I guess it would make sense if you're, with more TSH, but it's not significantly more TSH like it's not like cortisol. It's not the same circadian rhythm where cortisol is at the highest in the morning or ideally if you have a normal circadian rhythm, it should be cortisol pretty high, like decently high, not crazy high, but a good amount of cortisol should be secreted earlier in the day and gradually decreased. So I don't know if I would say a sudden spike. I'm not. The honest answer is I'm not sure if you get a sudden spike in thyroid hormone at 2 to 4 a.m. Related to the increase in TSH. Again, it would make sense. Although again, with Graves, obviously the pituitary gland is trying to suppress TSH. So yeah, like I said, I'm not sure if you get a sudden, and again, everybody I'm sure is different, but even if you get a spike, it's nothing comparable to like what cortisol would be. Um, yeah, and the thing is, most labs aren't open. It would be a nice experiment to go to the lab like in the middle of the night or I mean, saliva testing, unfortunately, not too accurate when it comes to testing TSH and thyroid hormones. Or because like with adrenal saliva testing, you could actually look at cortisol, like do a cortisol test in the middle of the night and look at cortisol. You can't. I mean, laboratories might have done. There might be some studies on that. I just haven't come across any or don't recall uh, coming across any where they're doing a test in the middle of the night to look at the comparing thyroid hormone production when comparing thyroid hormone production to different times throughout the day. Okay, Michelle. So elevated TRAB and elevated TPO antibodies. TSH very low, Graves diagnosis, no relevant symptoms. Should I treat naturally before symptoms appear? Okay, so you have the TSH receptor antibodies that are elevated, elevated thyroid peroxidase antibodies, TSH, again, so TSH very low, Graves diagnosis, no relevant symptoms. Should I treat naturally before symptoms appear? I mean, yeah, taking a functional medicine approach is definitely recommended before, like, yeah, like the conventional treatment approach. And again, even with this, maybe they would do something, but most of the times, if the thyroid hormone levels are normal from a conventional standpoint, and there's some endocrinologists would say, okay, let's just wait and see. But you have an autoimmune component here. Graves is more of an autoimmune condition than a thyroid condition. So even if this isn't just about symptoms, like when someone is working with me, yeah, like if they have overt hyperthyroidism and if they're not doing anything to help with the symptoms, if they're not taking, let's say, antithyroid medication, for example, then yeah, I'm going to do things to help lower the thyroid hormone levels, help with the symptoms. But even in someone who's not symptomatic but has elevated thyroid antibodies, especially TSH receptor antibodies, but then even the thyroid peroxidase or TPO antibodies, yeah, I would still say you want to do things to remove the triggers, heal the gut, correct underlying imbalances. So, yeah, in my opinion, I would say you do want to address the cause of the problem, even if you're not symptomatic. And yeah, so hope that answers your question. Probably need to come up. I don't know if I have a podcast episode. I mean, because you're really talking about subclinical Graves' disease. And I don't know if I don't think I have an episode. Let me actually, as a reminder, let's see, because I will forget if I wait until the ends of this. Where's okay, I don't know where that's not good. Okay, sorry. Subclinical hyperthyroidism. Okay, I'm gonna get back to some of the repeat questions, like not repeat questions, but there's some new people who haven't answered questions, and then I'll try my best to get back. I'll try my best to get to everybody. I can't guarantee I'll get to all questions. It depends on how many questions. Right now, as of now, I should be able to get to all of them, but depends on how many more questions we get in. So Jessica, my thyroid levels are good, but for some reason I'm getting a sudden spike in heart rate. I'm thinking it's panic attack or anxiety. It all lasts but a minute or less. And then she also adds that I can feel it incoming or oncoming. Yeah, so it could be adrenals. I mean, yeah, like you said, panic attack, anxiety, cortisol, like surges in cortisol could affect that as well. So you might want to consider adrenal testing, either adrenal saliva test or dried urine test like the Dutch test that looks at cortisol as well as the sex hormones. So Sean, any evidence, anecdotal or clinical evidence on healing the gut with elimination diets, strict carnivore, uh, the GAP diet or AIP diet to reduce inflammation and heal the gut, and how to tell if the gut is healed? There's not a lot. I mean, there's nothing really. I believe there's not evidence on carnivore or GAPS diet in the research, like showing that it's like completely healing the gut. I mean, the question is, what's the definition of healing the gut? So like. There's some evidence of benefit to these with these diets. Like there's one or two studies with AIP diet and Hashimoto. So far, nothing with Graves, showing that people with Hashimoto's could benefit and can help with the antibodies to some extent. But it's not really focusing on the gut microbiome. If anything, there's there needs to be studies showing like there's concerns with some of these diets like ketogenic, carnivore diet, even AIP, if someone's not eating enough plant-based foods, some of the potential negative effects on the gut microbiome. So yeah, so I think it's in most cases also these diets are a piece of the puzzle when it comes to gut healing. Um, and as far as telling if the gut is healed, I mean, there's a few different options. I mean, you could do, and again, the question is, what do you mean by gut healing? And when I say you, like not just you, what is meant? Like, what's the definition? Like, is it because you could test for a leaky gut? You could do a test such as, I mean, you could do zonulin, which is not my favorite marker, but that's if that's elevated, that typically means someone has that increase in intestinal permeability, that leaky gut. I used to do a lot of Cyrix Labs testing. Cyrix Labs, their array number 2, which is their intestinal antigenic permeability screen, their leaky gut test. So like if someone did that test initially, or one of those tests, a leaky gut test, and it was positive, and then you went on some type of gut healing protocol and retested whatever test you initially did, and now it was negative, then maybe you could conclude that the gut has been healed. But there are other ways of looking at the gut. There's stool tests that look at the gut microbiome, some of the commensal bacteria, also looking at opportunistic bacteria and pathogens. And again, those tests, rarely are they going to be perfect. So if someone did, let's say, like what's called a GI map, which is a pretty popular functional medicine test, and again, we saw a lot of imbalances, and then we retested and it was like 80% better, and the person's wasn't having any digestive symptoms. Let's say they were having digestive symptoms initially, but then no longer were having digestive symptoms and their antibodies normalized. I mean, again, even if the GI map wasn't perfect, can we still say that the gut has been healed? I mean, I would say, again, because again, the gut on these tests, very rarely are you going to have perfection, but it depends on, like, are you having like significant findings, or are you just having, like one or two of the opportunistic bacteria being elevated? So yeah, anyway, it does get complex, but it's a good reason to consider working with someone, working with, not, doesn't have to be me, but another practitioner. It could be who has working with the gut, which should be most natural healthcare practitioners. But yeah, it would be great to see some long-term studies on carnivore, on the GAP diet, on the with the AIP diet, on the actual gut microbiome. And so far, there's really not allowed. There are some smaller studies on the carnivore, like on a meat-based diet, short term. But I think short term is not too big of a concern. But if we're going to talk about 3 months, 6 months, a year, I think there definitely can be a concern. There is some evidence with ketogenic diet, I believe, in the literature showing that if someone's follows a ketogenic diet for a while, it can have some negative effects on the gut microbiome. And there's definitely overlap between ketogenic and carnivore diets. All right, just Jessica, just following up. So, and it's always at night. Thank you for answering. You're all welcome. So yeah, I mean, it could be cortisol. I mean, at night also, I will say, with elevated heart rate too, sometimes I think infections, like again, I'm not saying this is what you're dealing with, but sometimes certain infections like Lyme disease, Bartonella, even parasites could be more active at night, and sometimes they could affect heart rate, cause some tachycardia. So Marsha and Kevin, Hashimoto's hypo, been on T3 only for many years due to poor conversion of T4 to T3. Getting ready to transition back to natural desiccated thyroid. Checking salivary cortisol, iron, and magnesium levels. Anything else to check? I mean, yeah. I mean, well, if you talk about specifically conversion, I mean, those are some good things to look at. Selenium is another one that affects conversion. And then most of the conversion uh, it takes place in the liver. Approximately 60% of T4 to T3 conversion takes place in the liver. And then about 20% takes place in the gut. So now, looking at a liver panel, like a hepatic panel in the blood on a comprehensive metabolic panel, there's not really a great test when it comes to liver function, like looking at T4 to T3. So I usually just recommend to do things to support the liver, to reduce your toxic burden. But with the gut microbiome, especially with Hashimoto's or Graves' disease, I mean, the gut microbiome definitely plays a role in these autoimmune conditions, and again, can also play a role in the conversion. So that might be something to consider too. I mean, you could always start with the salivary cortisol, iron, magnesium. And I mean, obviously there are a lot of other tests I recommend, like vitamin D I recommend, but I wouldn't say that, as far as I know, I don't think that's playing a big role in conversion. So there are definitely other tests like for optimal health that I recommend. But I assume, again, you're just talking about like things for the conversion. So selenium, maybe looking at gut health. So Brittany says FNA came back, BET3 abundant Hertel cell change, only TPO high, due to chance of being cancer. Hard to know best thing to do. Yeah, I mean, for the nodules, yeah, when things are suspicious, I mean, you could still do things to address the cause underlying imbalances. And I do have some podcast episodes and articles on thyroid nodules, problems with estrogen metabolism, which you could look at. You could evaluate doing something like the Dutch test. Insulin resistance could be a factor, and you could look at fasting insulin, hemoglobin A1C in the blood. And then, I mean, TPO antibody of 42 is not crazy high, but you could still do things to optimize immune system. But yeah, as far as uh, next steps, again, I'm not sure what your doctor is recommending. There's also, depending on the case, RFA, radio frequency ablation, which can help. I had on the podcast Dr. Angela Mazza, and then I had a recent thyroid summit where I had her on again, and I think the first time I had her on the podcast, there wasn't really evidence of radio frequency ablation helping with suspicious or malignant nodules. But the more recent interview I did with her, she said that depending on the type of cancer, again, this is not specific, it's a chance of cancer. It's not, hasn't been confirmed, but that's an option too. And again, for those who are not familiar with radio frequency ablation, it's not radioactive iodine. Some people get confused. I not recommend radioactive iodine. Radio frequency ablation is specifically targeting the nodule. And so yeah, you might want to check out the podcast interview I did with Angela Mazza, Mazza. All right, Janet, I don't think I answered a question from you. Can we eat millet, kale daily for hypothyroidism? I mean, I don't know if it's Hashimoto's or non-autoimmune hypothyroidism, and if you haven't tested the antibodies, then you don't know either. But millet, I mean, I know some consider millet to be goitrogenic, and then kale is a cruciferous vegetable. I mean, I'm not a big fan of grains while healing. Usually, I recommend taking a break from grains and pseudo grains, but the cruciferous vegetables usually don't cause problems. I mean, if you're eating a few cups of raw kale, maybe that would be an issue, but most people aren't going to eat many cups of raw cruciferous vegetables. So if someone's eating, like a small amount of kale, either cooked or even part of smoothie, let's say, then I'm not too concerned as far as if you talk about goitrogenic properties. All right. So wide awake and aware 22. So I have hyperthyroidism and Graves and goiter, taking Lugol's iodine, and the goiter is reducing. All right. Well, wonderful. Thanks for sharing. I mean, yeah, iodine is one of those. Again, I speak about iodine, it seems like almost every time I do one of these calls because it's a common topic. I mean, iodine in some people can have amazing benefits, other people and can make things worse. So I had a real good experience with iodine many years ago, and as a result, when I first began working with people with thyroid and autoimmune thyroid conditions about 15 years ago, I was gung-ho on iodine and doing urinary iodine testing, and then if they were deficient, recommending iodine. But again, not everybody does well with iodine. It's not uncommon for iodine to make things worse, and there could be reasons for that. But even if you take the proper precautions, again, some people still won't do well with iodine. So, and I talk more about iodine in my books. Actually, all three of my books, I talk about iodine. So you could get any one of those and get my perspective on iodine. But I'm not anti-iodine. I'm just more cautious with iodine. But so I do appreciate you sharing that you're taking Lugol's iodine, your goiter's reducing. It's not the first time that has happened. I mean, that sometimes does happen. But again, sometimes iodine can make people worse, which is why, like I said, I'm definitely cautious. And yeah, you agree that every single body is different. Yep. but again, appreciate you sharing that. And then, yeah, Louisa says that iodine made me worse. And again, sometimes there's also certain precautions if someone is going to supplement with iodine, like taking selenium, for example, magnesium. But even once people take proper precautions, it doesn't mean that problems can't happen. All right, let me get back to some of the ones who already asked questions earlier, and I said I would get back. Um, oh, here we go. I think this is so winter kind. In my case, the trigger was a severe COVID infection. Can't take thyroid blocker. So in this case, LDN would be a solution. I already do everything you describe in your book. I mean, as far as if you're talking about where so you have COVID, you became hyper, you're unable to take antithyroid medication, and let's say you read my book and you took bugleweed, you took L-carnitine, and it didn't really help, then cholestyramine is an option, and LDN, yeah. So low dose naltrexone. Now, cholestyramine, the downside of cholestyramine is it might not be easy to get a prescription. So that's one challenge. Second, you need to take it away from everything. It's a binder, so it binds to food, supplements, other medications. So it's a little bit of an inconvenience. Then also it's in powder form. So but the upside is that it does seem pretty effective. I haven't had a lot of people on it, but pretty much everybody who's been on not LDN, cholestyramine, it has helped to lower the thyroid hormones. I can't say the same with LDN. LDN is more of a flip of the coin and just not as effective as I'd like to see. If it was 80, 90% effective, yeah, I definitely would recommend a lot more people to take it, even though it's not addressing the cause of the problem. But still, if it worked, it would be a much better option for most, if not all people, when it came to antithyroid medication. But again, not everybody. LDN, for those who are unfamiliar with LDN, it modulates the immune system, so it kind of calms down the immune system. But yeah, so LDN still something to consider if you have Graves. Now, if someone has, because COVID could also cause subacute thyroiditis, which is not autoimmune, and so LDN might not really be, again, it might not be effective even in cases of Graves' disease, but in subacute thyroiditis, then I would look more towards cholestyramine. But with subacute thyroiditis, usually it's transient, usually it's temporary. But yeah, thanks for investing in my book, for reading my book. I'm glad you're following the recommendations. I mean, I would still address, like, because COVID, I look at COVID or other viruses as the straw that broke the camel's back, like kind of a trigger, but there's usually other imbalances. So I would still do things to optimize adrenals, to heal the gut, to reduce your toxic burden. So still would work on all these things that I spoke about in the book, and some of the things I've also spoken about here. Um, okay, Hal, I will get to you. Just trying to get to everyone who hasn't asked a question first. And we have actually another. We have well, I was going to say another Eric, but it's actually Sarah Bryant under Eric Bryant's account. So Sarah Bryant was diagnosed with Graves in March of 2023. After you fell down a flight of stairs, and a trip to the ER led to the diagnosis. 6 months prior, my mom passed away, and I had COVID and was in a hospital for a week with pneumonia and tachycardia. Wow, I'm so sorry. After my diagnosis, my endo put me on 20 milligrams of methimazole. I sought help from a functional nutritionist, and I had severe leaky gut. I went on a strict diet and had a weight loss of 39 pounds. I'm still 50 pounds overweight. My endocrinologist reduced my methimazole to 10 milligrams. Let's see, you're got cut off. Let me see if I could. Uh, oh wait, this is not the. Hold on, I'm trying to go on the Facebook page and access because the question got cut off. All right, let's see. All right, so my endo reduced my methimazole. Okay, so after my diagnosis, my endocrinologist put me on. Let me see if I could just copy this here, like the whole question, so everybody could see. Okay, it's yeah, even me when I try copying and pasting, it's not. Let's see. So um okay, this should work now. What am all right, so all right, I posted in like every place that I'm streaming from three different places. So diagnosed with Graves in March of 2023, fell down a flight. Okay, so anyway, so the endocrinologist put me on 20 milligrams of methimazole, sought help from a functional nutritionist, had severe leaky gut, went on a strict diet, had a weight loss of 39 pounds, still 50 overweight. My endo reduced my methimazole to 10 milligrams. I'm at 10 months now and I have trouble sustaining my diet, but try to avoid gluten. I've changed personal and cleaning products. I'm taking Dr. Christensen's Graves supplements without iodine, and my hormones are balanced. My TSH is undetectable. My endocrinologist had me at 5 milligrams, but raised me to 7.5 because my TSH was too low. My endocrinologist wants to talk long term because I've been on methimazole so long. I need hope because I'm very discouraged and I don't know. Oh, did I? I don't know how to. Boy. I don't know how to continue with my journey. Hope this makes sense. Okay. Um, I mean, TSH, I wouldn't get discouraged based on, first of all, 5 milligrams, 7.5 milligrams is a very low dose of methimazole. So it's still, but again, the focus, you said your hormones are balanced. So T3, T4, um, I mean, the goal in the I would not worry about the TSH right now. And I know it's been a long time. Again, I have a podcast episode. How long does it take for the TSH to increase? And I have that podcast episode because it could take quite a while. It could, it's not uncommon for it to be 6 months or longer for TSH to increase. But, like, you've been on methimazole so long. I'll also say I have a podcast episode. Not that this is the goal, but I do have an episode that shows that taking lower doses of methimazole for quite a long time is fine as long as a person's tolerating it, as long as your liver enzymes are good, your white blood cell count is good. So endocrinologists that want to stop the methimazole after 18 to 24 months and then recommend radioactive iodine or surgery, they're just not following, they're not aware of the research. Again, I don't like methimazole, but if it's a choice between low dose methimazole and radioactive iodine or surgery, I'll always choose the low dose methimazole for someone who's tolerating it. And then while you're doing that, address the cause of the problem. Again, the supplement, it's great that you're taking a supplement and you again, the diet, sustaining your diet. But again, there's more than just diet and lifestyle. I have an entire book, The Hyperthyroid Healing Diet, and even in that book, I go beyond the hyperthyroid healing diet. So it's not like just diet alone many times isn't enough. So I could understand being discouraged, but the good news, you're on a low dose of methimazole. And if your endocrinologist is pressuring you to get off the methimazole, I would switch to a different endocrinologist. And you could show them the research. You could even show them the research. Don't show them like they're not going to want to listen to my podcast or read anything from me, but if you listen to the podcast, and I'm pretty sure I talk about the research studies, might even have them in the show notes, and you could show them that research. Here, look at this. These studies show that long-term methimazole, 10, 15 years is fine. Like again, especially when compared to removing the thyroid gland or getting radioactive iodine. And again, if they're not going to listen to you, because again, it's not you, it's the studies. And if they're not going to listen to the research, then find another endocrinologist, and in the meantime, address the cause of the problem. Which again, you're trying to do some of that with diet, lifestyle, but you probably have to do more than that because most people do. Karen, what do you know about applying the ice to the thyroid with hyperthyroidism? I mean, it's not something I recommend. I mean, we could make the argument for subacute thyroiditis maybe in some cases, but like if someone has like a lot of like really bad swelling and pain, not that that can't happen with Graves, but typically with Graves, it's not painful, the thyroid gland, the goiter, it's not swollen, like it's not, yeah, it's different. Like if you have an acute injury, that's completely different. But yeah, that's like I said, I mean, you want to address the cause of the problem. You want to, while doing that, have the person safe. Like, and again, that's where either the medication or the natural agents will help. Ice, probably not going to help too much. But if someone is having like subacute thyroiditis, hyperthyroidism associated with subacute thyroiditis, and even most cases of subacute thyroiditis is painless, but they're having certain types of subacute thyroiditis, they will have the swelling and the pain. In that case, maybe ice can be helpful. Okay. Hal, I'm going to get to your question, and then I'm going to finish up. I could only be on for a few more minutes, but Hal said, can you talk about the recent studies from China and Italy where they explicitly connect Graves' disease to the gut microbiota, different variety of bacteria of Graves people compared to control? I'll say that there is no question that there is a relationship between the gut microbiota and Graves. And yeah, there's definitely more and more research coming out, and there's going to be a lot of research in the future. I mean, when it comes to gut microbiota, not only Graves, but other autoimmune conditions, yeah, without question, doing things to modulate. I mean, it's not to the point where we're going to say, like, even if like certain studies show that, these specific microbes play a role I mean, because same thing, we could look at H. pylori, like, and we could say correlation doesn't always mean causation, but there's a number of different studies that shows that H. pylori could be a factor with Graves as well as Hashimoto's, and but it's not always necessarily going to be the factor. And some will say if the person's not experiencing symptoms such as heartburn or reflux, that not to address H. pylori even if it's positive. Which again, I can't say I do that, but yeah, there's definitely. I mean, I will say there's patterns that I see when I do testing. Like I see a lot of streptococcus, I see a lot of staphylococcus, unlike the GI map. I mean, there's like I said, there are definitely more common findings, but everybody's different. If I have put 100 people, if I have 100 people with Graves' disease and put together their GI maps, let's say, or whatever, it could be Genova GIFX or another, or just one that looks at the microbiome diversity. you will find commonalities, and that's what these studies are. They're not like you're not going to get 100% of people showing the same findings, but they're without question having a healthy gut important for the healthy immune system, which makes sense since most of the immune system cells are located in the gut. So yeah, definitely want to do everything you can to I mean, pretty much following the 5R protocol I speak about. So remove any factors that's having a negative effect on the gut. So certain foods, for example, if someone does have certain gut pathogens, want to address that. Replacing digestive enzymes, low stomach acid, dietary fiber, even re-inoculate with prebiotics, probiotics, doing things to repair the gut, doing things to rebalance the parasympathetic nervous system, to stimulate the vagus nerve, which also relates to the gut microbiota. So again, yeah, definitely all of this really important. Yeah, I've had yeah, definitely. I've had some, actually not too long ago, an episode where I spoke about Graves, I think specifically Graves in the gut. And, I think I did bring up, I don't know if anyway, I'm pretty sure I always, when I do studies or not studies, when I do podcast episodes, even like Q and A's, I'm typically doing research too. So, um, but yeah, so really important. Appreciate you bringing that up. Okay, I'm going to answer a few more. We have a few others. I'm probably not going to get to everybody here. um, this should be a quick question here from Louisa. Thank you for your help. I'm currently on your website looking for a gut healing supplement. Is it the SMGI? Yeah, the SMGI Restore. Again, um, if you visit guthealingbundle.com, there's 3 supplements, but the SMTGI Restore is the actual gut healing supplement that's part of the gut healing bundle. So, and then there's also a probiotic and a SMT Probio and Enzymes Plus, but the SMT GI Restore is what you're referring to. All right, there's So Crystal, I want to go finish your introductory video and start working with you to get to the root causes of my Graves' disease. I took myself off methimazole after my numbers got in line, but I'm guessing they're all out of whack, or they're out of whack again. My hair is falling out and a few other small symptoms, but overall doing well. Could you just give me a little feedback on what I might expect working with you? Are you currently accepting new patients? Yeah, so um and I'm gonna run by like 2:30, so about 7 minutes. So let me do this. So you might already be familiar with this, but if not, work with Dr. Eric. It gives more information, and we do require an application for people to work with me, just because not everybody is a good fit. And we want to make sure people are a good fit. So again, if you visit that, that'll kind of give you some guidance. But yeah, I mean, as far as when someone is working, I mean, we're working with me and my team. I also have nutritional health coaches as well, and functional diagnostic practitioners. But pretty much you meet with me, initial consults, you fill out health history form just like you would with any other practitioner. And then just if someone is not doing anything from a symptom management perspective, which is the case, like you stop the methimazole. So again, so I give recommendations for like typically bugleweed. If someone needs motherwort, for example, sometimes L-carnitine. So I'll give specific recommendations, dosing recommendations, what people should take. So we want the person to be safe, and then sometime, not a whole lot of time on diet and lifestyle, because people get a separate call with the nutritional health coach who again works mostly with hyper patients. So even though we do have Hashimoto's patients, but quite frankly, we see more hyper patients, people with hyperthyroidism graves, since there's not a lot of practitioners out there. So you have a whole another call, usually within a couple of weeks of the call with me on diet and lifestyle, and then I recommend testing, what testing we need to find the triggers, remove the triggers, or really initially to find the triggers. And I don't recommend a lot of supplements initially, if because again, my goal is not to just like give you like a whole bunch of supplements. It's to try to find answers. And then once we get the results, that's when we'll hopefully, depending on what types of testing we do, again, the hope is that we get the answers we need to give the recommendations. If not, then sometimes we need to do additional testing. And that's also part of the process is like, do we need to do more conservative testing or comprehensive testing? And a lot of that's also like, it's a two-way process. Like I give the recommendations, I might based on the person's health history, I might be more conservative with the testing, but give options if the person wants to be more aggressive, and vice versa. There are times when I think the person should be more aggressive, but they're on a budget and we just need to work with them. And if you want more information besides the workwithdreric.com website, you could also reach out to my staff person, Kate. So if you visit, let's see. Well, if you fill out the application, she'll get that. But even if you wanted to before that, she's not in today, but she's back on Monday. So again, you could visit her email is staff, STAFF at naturalendocrinesolutions.com. Her name is Kate. She's wonderful. She's been with me for close to 10 years. So, so yeah, that's what I would recommend. And then you mentioned you've been marketed heavily by Dr. Pompa and Dr. Axe. Have considered them. They focus on cellular health. One does at-home chelation. Again, I don't want to talk good or bad about all I'll say is you're not actually working, from what I understand, you're definitely not working with Dr. Axe one-on-one. Like you're working with his health coaches, like exclusively with so yeah, I know they have like $27 specials. Like I've seen them on Facebook, and then $27 is to have a call to talk to you into getting into a program, and the program is with their coaches, not with them. Again, I'm pretty sure Dr. Pompa also, it's not working with him, but yeah, cellular health, I mean, part of that's marketing. I mean, it's not, yeah. Anyway, so like I said, I don't want to say anything bad about them, because again, they're like myself, they're functional medicine practitioners, and ultimately they're looking to help people. They're just, they're on, I mean, especially Dr. Axe is on a different, like he's again, real well known. He doesn't have time to do consults, just because he's more like a celebrity almost. So he has like his health coaches. And anyway, so like I said, I don't want to say anything good or bad, because I personally have not gone through the program, so I don't know. But yeah, so yeah, so I'll leave it at that. And then you could speak with Kate with health insurance. Like we don't file health insurance. We have nothing to do. Like we don't do anything like health insurance. It would be up to you. Like you could file it, and there are people who do it on their own. So yeah, you could talk. Probably the best thing is to talk with staff person Kate. Okay, and then Sasa, that's what my suggestion. PTU, not even a year. Doctor wants radioactive iodine. I don't want this. How long can you take PTU in the dose? I'm not sure as far as like, again, if it's low dose PTU, then again, it should, and even if it's a medium dose, but the liver enzymes look okay, the white blood cell count it's really how you're tolerating it. That like 18 to 24 months, is just a number. When they say, okay, it can only be on it for 18 to 24 months. Like there's nothing in the research saying it's only 18 to 24 months. Again, like I said, the research actually shows the opposite, that the person's tolerating the medication. So if you're tolerating the PTU, again, it's not a long-term solution. Like ideally you want to address the cause of the problem, but risk versus benefits. If I had to be on either methimazole or PTU long term, I would rather, and if I was tolerating it, okay, I would not like being on it, but I'd rather do that and save my thyroid and still work on addressing the cause of the problem. So, okay. And Sarah says, thank you. I'm currently rereading your book and trying to find all those issues. I'm also trying to find another endocrinologist. Yeah. Yeah. That's definitely a time and place on that. All right. So, and then this is going to be the last one because I do need to run. I've been on for a little over an hour now and got to go. But Karen says, what's your thoughts regarding methimazole versus PTU? Having to switch to PTU due to reaction to methimazole. I mean, there's some people are able to tolerate PTU and not even when they can't tolerate methimazole. And there's probably like a 50-50 chance that you also react to the PTU. Some people are scared about scared of PTU because there are some studies showing that it could cause liver failure. Very rare. I mean, again, it could be harsher on the liver, but I've never had anybody in 15 plus years working with people with hyperthyroidism. Again, more people have been on methimazole than PTU, but a decent number have been on PTU. Again, I've worked with enough people with hyperthyroidism, and I have not seen anything like really bad happen with PTU other than liver enzymes elevated and the person has to get off PTU or having some other type of side effect, which is similar to methimazole. But I've never had anybody who was prescribed PTU and their liver, they experience liver failure. So risk versus benefits, it's again, if someone's facing thyroid surgery or radioactive iodine, it's in my opinion worth giving the PTU a try if they can't tolerate the methimazole. But remember, there's the cholestyramine, and then LDN, low dose naltrexone. I think if you go to my podcast early episodes, I mean, I have other episodes like on antithyroid meds, but I talk about some of the different conventional and natural treatment options. I know episode 3 is so savemythyroid.com/3. And I guess either episode 2 or 4, probably 2 would be conventional treatments. So, but check those out where I talk more about cholestyramine, low dose naltrexone, and of course, bugleweed, motherwort, L-carnitine. All right. Thank you so much. I'm sorry I didn't get to I mean, I think I got to everybody at least once. I just wasn't able to get to everybody's repeat questions. But again, appreciate the questions. Again, hope everybody has a great rest of your Friday. Thank you again for tuning in. A great weekend ahead. Hey, Paola, I'm getting ready to leave, but yeah, nice to see you. Hope you have a great weekend. Crystal, you are welcome. And yeah, Karen, you're welcome as well. And and Louisa, yeah, there's no, I don't, yeah. What I do have some live events a few times a year. So in January, I will be having another live event. So feel free to attend that. And yeah, so, but I don't do like Patreon or anything, you're on YouTube. So with the super chats and all that. So maybe in the future I'll consider that. But right now I'm not doing that. So this is completely free. So, but again, thank you. And everybody, again, have a happy Friday and a great rest of your weekend. Take care, everyone.